Rebekah, I'm so glad we're doing this morning. Thank you, thank you, thank you. It's rainy and dreary here, and you're such a bright spot for me personally, and I know you for everybody else. Our Dr. Rebekah, you are an OBGYN, recently became CEO of Healthcare Services for LSU Health. Until just a few months ago, you were Secretary of the Louisiana Department of Health. You were responsible for the health of 14.5 million individuals and the state's largest agency with a budget of $14 billion, where your responsibilities included public health and other direct service programs for citizens in need, such as behavioral health, aging and adult services, emergency preparedness, and the Medicaid program, which I would just add appear to be pretty fitting areas of expertise for right about now. You've done amazing work in helping secure PPE across the country. We're talking about now, there's this new term, EPE, which I love, like emotional PPE. And you sent me an article on Monday about Dr. Warner Breen, the ER doc. What was it about that story that hit you so hard?
It's just the fact that we're expected as caregivers to be so strong, and we have to be on the front lines. We're putting our lives on the lines when we go into situations, particularly in a COVID situation where you don't know as a healthcare provider that if you could get it or not, and if you did get it, could you die from it? And the fact that this woman who was so strong, who was working at my alma mater at Weill Cornell, and obviously so talented and full of life, that she didn't see a way out, didn't see hope. And I wonder if who reached out to her in between the time when she really felt this trauma and she decided to end her life. I think that this shouldn't happen again, and whatever needs to be done, it needs to be done now, because people are still experiencing trauma now. And this is really the important time for people to process. You don't want to wait. We know a lot about adverse childhood experiences, for example, that the more you can do early on to intervene, the better the long-term outcomes. We want to intervene now and allow people to process and care for the caregiver. I also spoke with 2 critical care doctors the other day, and they said, look, they use the word pampered, which I kind of like. They just said they haven't been pampered. They haven't felt like they're special. They haven't felt valued. And that's not good. Look, these people are heroes, and what they had to do every day, particularly in Louisiana, we have experienced something that most parts of the country haven't. New York has, Washington State has, but we had a month, and this was really the end of March and a few weeks into April, where we were worried about not having enough ventilators. People were having to reuse masks, put them in paper bags. People were dying. I mean, we had the highest growth rate in the world at that time in cases. And so what we saw was very traumatic, and it really is important that we address this now. And in fact, we're working on that at LSU, the head of psychiatry, and I had a conversation yesterday about a town hall and making sure everyone knows that we can talk about it, that we can acknowledge what people are feeling, so that those who are traumatized don't feel bad. They know that's normal, and we address it right away. So I'm excited that we're going to be doing that starting this week.
You're bringing up something that I've been reading about this past week, the concept of moral distress and moral injury. These terms originating in the treatment of combat veterans really is, in a way, here what is happening now. It's very analogous to war. And it's really about characterizing the impact of being forced to engage in actions contrary to one's moral values. And there was historically about if the rules and regulations, insurance demands, and expectations of corporate medicine in America had created that for doctors and clinicians. There's also this concept I'd never heard, hero professions, which stands for high expectation for high risk occupation, which is used in reference to professions where there are high expectations of performance and high risk to self and others. That's clearly acknowledged as true for police, firefighters, military, but there was debate about whether or not medicine fell into that category. And most could now say with COVID, that's clearly not true, right? This is a hero profession. So what can we be doing? What should we be doing to mitigate moral injury?
See, first of all, we need to, one of the things that we realized was we need to do more drilling on these types of scenarios. Look, we have crisis standards of care. They were first developed by the National Academy of Medicine in 2009, partly in response to events like September 11th and Katrina, where we need to think ahead of situations where we might have limited assets and how would we make decisions for patients and understand what we would do. We need to think ahead of time about that. In addition, we certainly need to think about racial equity as we make those decisions and understand our own biases, and these guidelines need to be looked at again. But the more we can do to prepare people before events like this, for this eventuality, the better. And then I think it's just having a team on hand to make sure that you don't have to call a psychiatrist. Look, doesn't mean you have a mental illness if you have trauma, but you need to talk to a professional. So we should have teams of psychiatrists, psychologists, social workers, and peers on staff on hand so that you can call any time and debrief. So I think similar to what happens when we have a terrible outcome, we've implemented this with maternal mortality in Louisiana. If a woman dies in childbirth, that's a never event. And not only what happened to this woman, but what happened to that team is traumatic, and we need to debrief. And ideally, you debrief as soon as possible so that you learn from what's happened and you're able to share your feelings with your team and get support. So, look, we're not doing this quickly enough. And I think we need to learn from this epidemic that, as you said, healthcare is a hero profession. It's not just doctors, it's nurses, it's psychiatrists, social workers, people on the front lines, and they need support too. And so that you're helping to lead this national movement, which is so critical, and your leadership and vision has been so powerful in making sure that this conversation happens in all of the circles where it needs to. But look, every institution should be really thinking about what is their crisis trauma counseling plan, and not assume that doctors are strong. Look, we're taught to not show emotion. We're taught to segment those feelings when we have loss, don't cry in front of patients, all of this. But look, we need support too. So to nurses, so this is a wake up call, I think, for that. And certainly the death of the ER physician is a tragic loss that maybe could have been avoided with better counseling.
Yeah, and I love your point that there are professional channels through which to get that counseling, and they need to be boosted and strengthened. But there's also the opening up of a culture that normalizes to talk to your peers and normalizes that this is very real. You're not alone in it. This is not a symptom of not being strong. It's just a way to be surviving together. So, Rebekah, will you share a story around this notion of trauma and caregivers from now or from before, and specifically related to that, what can an employer do right now to make a difference?
So the most traumatic thing that's happened to me as an OB was when I had a woman come into the emergency room when I was a resident who was on her way to her baby shower and got hit by another car, sideswiped, and came into the emergency room. Her baby was still alive. We tried to do an emergency C-section with an X-Acto knife, and they both died. And it was incredibly traumatic. She was in a beautiful dress and her makeup on, and all of the hope and all of the anticipation that she had that day on her way, and the horrible trauma, tragedy that happened. So, but the hospital did a great job of bringing us together to say, look, do you need to talk? Do you need counseling? And that happened immediately, like the day after. So I think that's the kind of thing when we have people that are in intensive care units dealing with loss, we need to we need to proactively reach out to them, number one, to say, are you okay? But then build in, and in some cases, I think we need to require that they get assistance. Build in the time, an hour of self-care, and in that hour, allow for access to mental health professionals, or even just require a discussion with somebody. I think that's important, because what you need to do is normalize self-care. You need to reduce the stigma, make it accessible so that people will use it. Because particularly nurses, physicians, caregivers, people that are used to taking care of others are not going to take the time to care for themselves until they're forced to. Yeah. So I think it's important to build these.
Yeah, a lot of the individuals will, because of this, associated, because their own sense want to feel as though they're okay, they're out helping others, call a 211. They won't reach out to some of these resources that exist. So instead, do you build in as a foregone conclusion, presumptive close, that of course now you'll spend some time
Right.
with someone talking through what's going on.
That's
And
right.
can
And
you
that,
talk about, yeah.
yeah, and then there's no stigma to it. That's just acceptable. That's what's part of the caregiving, is being cared for.
So you're an executive, a policy expert, you're a doctor, public health, genius. I'm the CFO of that employee, of that employer, responsible for these employees. Remind me why this actually makes good fiscal sense. This is not charity. This is actually smart for you. You should do it because it's the right thing to do. But in case that doesn't turn you on, why else should you do it?
Right. Well, certainly mental health challenges like depression, anxiety, PTSD can affect productivity. In its most glaring sense, certainly suicide. I mean, think about the opportunity cost of all the training and all of the investments that employers are making in caregivers. They want those people to be productive. So people are more productive when they have good mental health, when they're cared for, and when they're not traumatized. So that's, I think that's the economic imperative.
Well, and I'll just extend beyond the clinical world to unpaid caregivers. Caregiver has an unpaid caregiver at home who's stressing out, and many of those are also caring for parents and kids and neighbors and families. So this notion, when you're in that stressful situation, the impact on productivity, the decrease in your own health, the decrease in resiliency, these are all the opportunities for you to be doing something that's good for the universe, and also ultimately will be good for you as well financially.
Yeah, I mean, prevention is very money saving. Think about we think about how many trillions of dollars we're going to have to spend on COVID, and think about if we had just several hundred million investment in the infrastructure around public health surveillance and testing, public health departments, public health nurses. That certainly, would have reduced the transmission of this disease and saved us a hell of a lot of money. So, I mean, prevention's a lot cheaper than the not prevention. So I think that we've certainly learned that from COVID.
There's also, you talk so beautifully about this notion of the PTSD that we're going to see in clinicians after. And it is expected that we will see depression and anxiety and grief and sleeplessness, survivor guilt and hypervigilance, a lot of the stuff that you talk about. But there's also the hope that I think you speak to so well, that we'll see post-traumatic growth, which is a term I'm really coming to love. Did you see post-traumatic growth in New York or after the floods, or retrospectively in what you saw from folks with Katrina? Any example?
Well, look, I've seen it in my own life. In 2008, I was on a scooter in Philadelphia on Augusta, and my husband and I were going to a birthday party, and we were hit by an SUV, and he was killed, and I spent 3 months in a wheelchair. And the learnings from that experience, both that have made me a better caregiver because I was cared for at that time, of the change and priorities, the reminder of what is critically important in life, and how to what is important to me, and how to spend every precious day. That really changed my life, and I wish that it hadn't happened, but I certainly felt it was a growth opportunity. I think likely Katrina was a growth opportunity. We're not where we need to be, but our public education system is better here in the greater New Orleans area. We have better spaces and places for people to be. We have billions of dollars that have been put into our levee system to bolster and strengthen them. We're doing better planning to protect our coast, and all of that has happened largely as a result of the experience of Hurricane Katrina. So certainly what we do and need to do is build back system. When you break a system, you need to build it back better.
Yeah, amen. Okay. Anything else? Anything else to share?
No, thank you. Thanks for having me.
I love you.